Topic of the lecture today is tissue nematode infections. In this lecture, we're going to talk about all those nematodes, all those parasites which affect our tissues, which infect our body and rather affecting any other organ or any other place, they rather go to tissues. And they affect rather different tissues than affecting a similar tissue or affecting the same tissue again and again. So affecting different tissues depend upon the species at which species of nematode is affecting our body, and different species have trends towards affecting different tissues. Now, let me tell you that these species or these nematodes are not hunting for humans. They're not there to affect our tissues. They're not there to prey on us. They're actually going through their life cycle without affecting us. They don't want anything to do with our tissues or with our body. But when they are circulating with their life cycle through different animals, so different cats, dogs, this goes on, and somehow we manage to ingest them by eating that animal or by getting in contact with that animal. But once we get them in our body by ingesting them, what happens is that is their dead end. We are dead end organs, or we are dead end organism for these nematodes. Afterwards, they're gone. They can't do anything about it. So what they do is that they go through their life cycle in our body, and then they go on and affect our tissues. Then they go on and embed themselves in our tissues. And different nematodes have tendency to affecting our different tissues. So in this lecture, we're going to talk about different nematodes and their tendency to affect our tissues at different levels. So first of all, we're going to talk about visceral and ocular larva migraines. Now, this is a condition actually. This whole thing is a condition actually that these larva migraines are affecting us at two different levels. Either they're affecting us at visceral level, in which what will happen? Our organs will be subjected to that. Visceral means organ. On the other hand, we have ocular larva migraines. Ocular meaning eye, meaning that T. canis is going to affect what? Either our viscera or what? Or our ocular areas with these larva migraines. What do they look like? This is what they look like. These are larva migraines, or these are taken out of our systems, so that you might get an idea of them, that how do they look like, these larva migraines, and how are they going to infect and affect our visceral levels and our ocular levels. So let's start with the life cycle of it. Life cycle starts with cats and dogs, obviously. I told you that we are not the definite host. They are not looking for a human tissue. They are not even preying on us. They are going through their life cycle on their own through cats and dogs. And let me tell you, afterwards what comes on, different animals and soil, all of these are factors. All of these are passages. All of these are steps in their life cycle. They don't want anything to do with human tissue, but accidentally they will bump into us. We will ingest them, or somehow we'll get in contact with them, and we will get their larvas. And once the larvas are in, what's going to happen? They're going to affect our tissues. So in the life cycle, what happens is that these dogs and cats have this pathology, and they pass on eggs of this organism in their feces. So what happens afterwards? These ingestion of paratenic host. Now, for example, dog is going to eat cat, or dog is going to bite cat. So this will get eggs out of it. And we have seen multiple times that multiple dogs feast on the fecal material. So maybe those eggs were passed on by this cat, and then that fecal material was ingested by this dog, and that's how it got those eggs. Once it got those eggs, what's going to happen? Toxocara canis comes out of it. Toxocara canis comes out of it in dogs, and Toxocara cati comes out of it in cats. These are two different terms you have to remember for dogs and cats. What happens afterward? Vertical transmission will come through. You know vertical transmission is, right? From one another, vertical transmission will come through, in which what will happen? Adults in small intestine of offspring. Now, adults are found in the small intestine, and the offsprings will come out of it with what? Unembryonated eggs. What will happen then? They'll convert into embryonated eggs through different procedures, and once they have achieved the L3 larval stage, whatever nematodal life cycle you are referring to, whatever nematodal life cycle you are studying, in most of those life cycles, you'll see that L3 larva is the larva we consider mature enough. We consider larva enough to infect any other organ or infect any other species or organism. What will happen? Somehow, this ingestion of eggs is going to happen in our case. We just ingest them. We ingest them how? There can be multiple scenarios in which we ingest them. We got into contact with them. We ate them. Many cannibalistic activities go through this phenomena. Many cannibals go through this phenomena, or we got in contact with their feces somehow, or whatever the scenario is. You got in contact with the eggs and you didn't wash your hands. You put your hands in your mouth, and that's how it got into that. So there are multiple scenarios in which we can get the egg out of this scenario, and once we ingest them, what's going to happen? What's going to happen is that all of this tissue pathology will come on. We're going to talk about what tissue pathology will be coming on. We're going to talk about what ocular manifestations are coming along. We're going to talk about what visual manifestations are coming along. But for now, this is how we got these eggs, by just getting in contact with them. Now, somehow these embryonated eggs, these L3 larvae, can get in contact with what? With ducks, right? With rabbits. Now, we eat rabbits, right? So that's how we can get them into our body. That's another way of getting the eggs or this parasite in our body. And then these foodborne transmissions are going to get into our body and cause this pathology. Now, these L3 larvae are going to do what? They are going to migrate in our tissue. I told you we are dead and host to them. So what they are going to do, what these L3 larvae are going to do, they got into these ducks, they got into these rabbits, but they were fine. They were at least trying to complete their life cycle. But somehow, if through foodborne transmission or getting in contact with that, somehow led to ingestion of these larvae in our body, these L3 larvae are going to migrate in our tissues and cause these pathologies. Now, L3 larvae are present in the tissue of the ducks and all the other animals which somehow got in contact with them. And who's going to eat it? Dog. Somehow dogs got in contact with them or ate them or preyed on them, and they got this L3 larva again, and then this life cycle continues again and again and again. So that's how it happens. So we are not their definite host. We're definitely not their definite host. What's going to happen is that we are accidental host. They are feasting on, they are preying on dogs, cats, ducks, rabbits. They're completing their life cycle in that in those animals. But what's going to happen is that through foodborne transmission or through contact of these eggs with our hands or whatever it is we're eating, it will lead to these parasites into our body. And then what will happen? These L3 larvae are not going to stay in your intestine. They're going to migrate in your tissues, and they're going to affect your tissues. Now, these embryonated eggs with L3 larvae can directly go back to dogs too, right? So there are multiple chances of we not being infected at all, because we're not the primary host they're looking for. These are the larvae. They can either be taken up by the dog, they can either be taken up by the rabbit or ducks. And if rabbits and ducks are being consumed by dogs, this life cycle continues. But what happens is that through foodborne transmission, somehow accidentally, we get in contact with them and we get this pathology. Now, ingestion of eggs, we talked about it. Somehow the dog will ingest these feces or these eggs somehow and will get this infection again and again, and the life cycle continues. Now, these adults in small intestine of definite host are present in what? Toxocara canis in dogs and Toxocara cati in the cats. Now let's talk about the clinical features of these visceral larval migraines, not ocular ones. We talked about it has two manifestations, it affects two basic tissues. Either it can affect visceral parts or organs, or it can affect the ocular levels or eye. And we're going to talk about the clinical features of visceral larva migraines. Now, what clinical features will be coming along if it's affecting the visceral level, right? So what you will see is fever. First of all, because a parasitic infection, no matter what, it's an infection, our body is going to respond, our hypothalamus is going to respond. And what they do in respond is they raise the body temperature in order to combat these parasites, in order to combat these pathogens. So you will have fever, you will have malaise because of this fever. First of all, because of this fever, and second of all, because of the ongoing infection, and you're not eating properly and not resting properly, you'll get this malaise. Next one, you'll get anorexia. You won't be able to eat properly because you have been in contact with some parasite which is right now harboring in your intestine and moving towards your tissue, completing its life cycle in your body. So what's going to happen is that you are going to lose your appetite and it's going to lead to anorexia. Next on, it will be weight loss. Weight loss, why? Because visceral levels are being affected, organs are being affected. They are being harbored by these parasites. You're not eating properly. You are anorexic. You are going through fever. All of these factors combined will lead to weight loss because your consumption of food has decreased significantly rather than before. So you're going to lose weight. Next on, you'll have cough. If it's going to affect your lungs, you're going to have cough. It can lead to pneumonitis. It can lead to further very much pathological consequences in your lungs. So what's going to happen? What's the immediate symptom or clinical feature that you look for is cough. Next on, you will have wheezing. Wheezing because in some infections of these parasites, they're going to affect your lungs and cause hypersensitivity, and this leads to wheezing. Next on, you will have rashes because of this hypersensitivity, and it affects also the cutaneous layers. So the rashes might be because of that too. Next on, you will have hepatosplenomegaly. Now, most of the infections we study in nowadays lead to hepatosplenomegaly, right? So this is one of those infections which will lead to hepatosplenomegaly. Your hepatic size will increase, your splenic size will increase because of this infection, and this parasite might be harboring themselves in it. Next on, you'll have series of behavioral disorder. What is series of behavioral disorder? This will be because of psychological consequences and mental affectivity. If your mind is being affected, you'll lead to series or behavioral disorders. Series meaning if it's affecting your brain, if it's affecting your CNS, what's going to happen? You're going to have series. And if you don't get series, you'll get behavioral disorders in which you will be doing this kind of stupid activity. You will not be responding properly in an environment. You won't be a practical part of it. You will be a standalone. You will have these behavioral disorders. Now, all of these are clinical manifestations of visceral larval migraines, right? What will be the clinical manifestations of ocular larval migraines? First of all, we talked about it's going to affect your eye. It's another tissue it's going to affect. It goes to your eyes and cause these following pathologies, these following clinical features that we're going to talk about. First of all, you will have strabismus. What is strabismus? I hope you have studied strabismus in your eye exams or eye books. But let me tell you, strabismus is that if you get this pathology, if you get strabismus, what happens? Your two eyes won't be able to focus on one thing, right? Either one eye will go up and other will go down, or the other will go up and the second one go down, or they can just migrate towards the lateral side. They can just go towards the lateral side. You are looking at these things, you are trying to focus on a TV. For example, you're watching a television. What happens is that maybe this eye is focused, this eye stays focused, but this eye will move to the left. So that's what strabismus is. Uncoordinated eye movements are called strabismus. So when you are going through this infection and it's affecting your ocular levels, these larvae are affecting your eye levels or eyes, it's going to lead to strabismus. And most of these cases can be due to nerve involvement or due to muscle involvement, right? So first of all, you'll get strabismus. You can get eye pain. Obviously, there's a parasite in your eye. It's affecting your muscles. It's affecting your nerves. You are definitely going to get eye pain because of it. Next on, you will have eosinophilic granulomatous mass. Now, we talked about in any parasite infection, name any parasitic infection, first of all, the blood levels of eosinophil will rise. We've talked about it multiple times in covering these infections and specifically these nematodal infections. We've talked about it multiple times that they are going to increase your eosinophils. So what happens is that in this pathology in which ocular levels are being affected, you will not only get raised eosinophils, you will get eosinophilic granulomatous mass in your eyes. Next on, you will get unilateral visual disturbance. Now, whenever you mention the term visual disturbance, it's because of the nerve involvement. So unilateral visual disturbance is significantly high in these cases. Patient gets loss of vision of one eye or disturbed vision of one eye. So it's rather common in these scenarios. Next on, you'll have endophthalmitis. Next on, you'll have uveitis, which are actually inflammations. Now, uveitis is inflammation of the uvea. Then you'll have chorioretinitis. All of these pathologies, it means that retina is being informed, chorea is being informed, uvea is being inflamed. All of these structures are being inflamed right now. Uvea, chorea, or retina, they're being inflamed because of this infection. So, ocular manifestation involve what? Inflammations that involve retina, chorea, uvea. All of these structures can be inflamed, or it can lead to strabismus, or it can lead to endophthalmitis, or it can lead to what? Visual disturbances in at least one eye of the patient. Now, these are the clinical features of this parasite in your eye at the ocular levels. These larval migraines are going to cause these pathologies in your eyes. Now, how do we diagnose it? Both of these, visceral and ocular larva migraines. How do we diagnose them? In many cases, we have studied and after some time, we have come to know that when a patient is being affected viscerally, it doesn't take much of a time that it goes on and affects your eye. So in some cases, both of these are present. Both of these affected sites are present. So how do we diagnose a patient who is suffering from visceral or ocular larval migraines? First of all, eosinophilia. We talked about it in any nematode infection. First thing to rise in your blood is eosinophils, so you'll have eosinophilia. And in your ocular levels, you will having what? Eosinophilic granulomatous mass. Next on, you'll have leukocytosis because leukocytes are going to respond to this parasitic infection, and that's why you'll have leukocytosis. You have hypergammaglobulinemia. You'll have hypergammaglobulinemia. Now, this will also be an indicator for this parasitic infection. Next on, you'll have chest X-ray, in which you will see this pathology, in which you will see this disarray. That will be because of this parasitic infection. It's affecting your lungs. We talked about it before. And then for the further and confirmative diagnosis, you'll go for ELISA and you'll see these strains and you'll get to the diagnosis. Now let's talk about the treatment options we have. One thing we have established by now is that they are not going anywhere. They are going to infect your tissues. They're going to get into your tissues. They're going to cause these ocular manifestations. These are going to cause these visual manifestations. And if somehow you diagnose them at the proper time, what kind of treatment you would go for? First of all, you have to know that which of these manifestations are being presented. Either these are ocular or visceral, right? You diagnose them, but you have to be sure that if ocular manifestations are there, you have to treat them accordingly. If visual manifestations are there, you have to treat them accordingly. So first of all, if it's visceral larval migraines, what do? If it's mild to moderate, you just give supportive treatments. And if it's severe, you give glucocorticoids. Now that's a treatment option we have for visceral larva migraines. Now, what do you mean by supportive treatment? Whatever this larva is affecting in your body, just comprehend that. Just compensate that. Give supportive treatments. And if it's severe in nature and causing all of those clinical manifestations we talked about at visceral larval migraine level, we have to go for the glucocorticoids, and they have been proven out to be very helpful in these cases. Now, let's talk about the ocular manifestations. If the ocular manifestations are there, if the patient is having strabismus, if it's having inflammations, if it's having problem with one eye or both eyes, or having problem with even visual fields, what do? You go for the treatment options which are not fully defined yet, but what do you go for? You go for albendazole and glucocorticoids. Now, you were already going for glucocorticoids in visceral larval migraines, but what did you add in an ocular manifestations? You added albendazole with glucocorticoids. Glucocorticoids, as I already told you, have been proven out to be very successful in the therapies of this nematode. So what we do is that we do give glucocorticoids, but along with it, we prescribe albendazole. Now let's talk about the cutaneous larva migraines, right? And this is caused by Ankylostoma brasiliensis. Brasiliensis. That's how you pronounce it. So we talked about visceral larva migraines. We talked about ocular larva migraines. Now we're talking about cutaneous larva migraines. And they are going to be caused by this parasite, this nematode. Now, most of the people believe that these are actually hookworms. These are actually the subspecies of hookworm, and they affect your skin. You have heard about these rash coming along with nematodes. You have heard about this skin cutaneous manifestations coming along with these parasitic infections. That's what it is. It affects your skin. And at cutaneous level, this is what it looks like. You can see the end of it. It might get attached to your skin. It might destroy those cutaneous level and cause further pathologies, cause these rashes, these hypersensitivity reactions. And that's what these cutaneous larval migraines are for. So cutaneous larval migraines, whenever someone asks you what organism or what parasite causes cutaneous larval migraines or cutaneous manifestations specifically, you have to remember this Ankylostoma brasiliensis. Next on, let's talk about angiostrongyliosis. Now, it is caused by Angiostrongylus cantonensis, right? So what happened? This is what it looks like. So let's talk about the life cycle of it. The life cycle of this starts from what? A mice. Most of these angiostrongyliosis start from the level of mice. What happens is that mice, if they're present in the mice, and let's talk this out, adult in pulmonary artery produces fertile egg, right? And these larvae hatch, penetrate arterioles, migrate up to bronchi, and are cuffed up, swallowed, and passed in the feces. We have already talked about it. Next on, these larvae are consumed by a land snail. When land snail consumes them, which is present in the fresh water and it's viable there, it's going to go to what? It's going to go back to the rat, and this life cycle continues. But if somehow we consume them, these land snails or these rats, and third stage larva penetrate our gut and goes to CNS, that causes angiostrongyliosis. It's going to do what? It's going to go to your intestine. It's going to get absorbed in your blood, into your arterioles, into your venules, and going back to your heart. From there, it will go to your lungs. From there, it will come back to your heart. And from there, the heart will pump this to your brain, to all other vital organs, and the brain is going to get it. And this might lead to this parasitic infection. The time it takes is actually 2 weeks. That's incubation period for it, and it can lead to eosinophilic meningitis. So if you just look at it, it's rather very easy to avoid such parasitic infection, right? Just avoid the mice, just avoid the land snail, because that's their primary life cycle. They're not there to hunt a human being. They're not there to cause meningitis in human being. They are just going through their life cycle between rats and snails. Rats ingest them, it goes into their body, they get absorbed into their blood, go into the lungs. That larva is going to migrate up to their mouth, their larynx, and then be absorbed into their pharynx. And then these larvae go to the intestine, and then they pass them on into our feces, into their feces. When they pass on into the feces, they somehow get in contact with these land snails, right? These land snails ingest them, they have these larvae. Now these two are the primary targets for the life cycle of this organism, this parasite. But if somehow we get in contact with them, we're going to ingest them, they're going to go into our intestine, they're going to pass through our small intestinal mucosa, pass over small intestinal levels, go into the blood, and once they're in the blood, they go into the heart, then from the heart, they go into the lungs, from the lungs, they go into the heart, and then from the heart pumps the blood to supply brain and all other vital organs with the blood supply and the oxygen demand they have. And this leads to the delivery of this parasite into your brain. Now it has an incubation period of 2 weeks. After 2 weeks, you will start to have these symptoms. We're going to talk about those symptoms, but this will lead to eosinophilic meningitis. Now let's talk about the clinical features of angiostrongyliosis, which led to meningitis, right? So let's talk about the clinical features. First of all, you will have this abrupt, excruciating frontal, occipital, or bitemporal headache, because they're attaching themselves there. They are attaching themselves to your brain. They are getting into your brain. This can be any site. So you can get an excruciating pain in either frontal lobe or occipital lobe or bitemporal lobe. And you'll have this frontal, bitemporal, or occipital headache. This is the first sign or the first clinical feature you will get with this angiostrongyliosis. Next on, you'll have neck stiffness. We talk about neck stiffness in all the cases of meningitis, right? When this organism has made its way to our brain, it's present in our brain, it's not going anywhere from there, it's attaching itself to the brain, and it's causing the pathology, it's causing that infection, it will lead to eosinophilic meningitis, and that will lead to what? Neck stiffness. It will go harder and harder. Neck stiffness will increase and increase, because the infection is under the process. The infection is ongoing. It's not like infection is gone. This parasite is still there. You don't even know this parasite is there. You have not even started to treat it yet. So this is an ongoing infection, and this will lead to more and more neck stiffness in the coming time. Now you will have nausea, and nausea can be because of any reason, like neck stiffness or this excruciating headache we're having. Next on, vomiting can be there. Now vomiting can be related to many things here. It can be related to meningitis, it can be related to excruciating headache we're having, it can be related to this nausea we're experiencing, and it can be related to our GI consequences of ingesting the eggs of this pathogen or this parasite. Next on, you'll have paresthesias. Now what is paresthesias? Paresthesias are actually abnormal skin sensations. Now these abnormal skin sensations are actually burning, tingling. These sensations are called paresthesias. Now these paresthesias and the consequences we're having these paresthesias are because of what? Because of the brain involvement. When brain involvement is there, nerve involvement is there, and you will have these paresthesias, you will have these tingly, burning sensations in your skin, and there will be no apparent reason for it. But the reason behind it is this brain involvement, this nerve involvement. Next one, it will lead to fever because of the ongoing infection we have, because of the involvement of the brain and higher mental functions. We're having this fever. Next on, you will have cranial and extraocular nerve palsies because nerves are being entrapped. nerves are being destroyed. So you'll have these cranial and extraocular nerve palsies. So these are the first nerve palsies you will get to know. Other nerve palsies can also come along, but these are the first nerve palsies you will come to know in very early cases of eosinophilic meningitis. Next on, you will have seizures. If it affects basic part of your brain, major part of your brain, it can lead to seizures. Now, it can also have rather pathological consequences like paralysis, in which if the nerves which control your lower body, which control the movements of your lower body, are being affected or being led to these pathological consequences, that will lead to paralysis of your body, of your lower body. Now, it can be your lower body, it can be your upper body, it can be any part of your body. If nerves are being affected, whichever nerve is being affected, that side of the body or that part of the body that it was controlling is going to be lost. Next on, you will have lethargy. Now, lethargy is rather lower of a clinical feature in comparison to all these paralysis, seizures, cranial palsies we're having, but it's very early clinical feature that you look for. In the very early stages, you will look for what? You will have these headaches, you'll have a mild neck stiffness, you'll have lethargy. This will go on into nausea, vomiting. This will go on into cranial and extraocular nerve palsies. This will go on into paralysis. Now, these are actually steps of clinical features. Whenever this infection is harboring itself in your brain, whichever part of your brain is being affected, the clinical features will be according to that area. Next on, we'll have laboratory findings. How do we diagnose such a drastic pathology? How do we diagnose such a drastic pathogen which may lead us into paralysis forever? So how do we diagnose it? First of all, you'll go for the history of the patient. Let me give it back. Before heading into examination of CSF, you'll go into the history of the patient. You'll ask all the questions which are needed. Because whenever a patient presents to you with meningitis, you always suspect what? Bacterial meningitis or viral meningitis. No one suspects, even fungal meningitis, but no one suspects in any scenario that this might be due to a nematode. This might be due to strong elicit. So what we have to do is get a proper history. Ask all the important questions, all the necessary questions which might lead us to our differentials. And once we have done that, we'll go into examinations. And in examination, you will look for all these clinical features that we have talked about. You'll ask about nausea, you'll ask about vomiting, you'll have these nerve examinations and which of these nerves are being affected, which nerve palsies are we having. All of these findings will be very important in establishing the diagnosis, in establishing the differential diagnosis. And once we have known all of it, you'll go for what? You'll go for CSF examination, because you go for CSF examination anyways. Whenever a patient presents to you with neck stiffness and you suspect meningitis, you always go for CSF analysis so that you might get an idea, you might get the confirmation whether it's bacterial, whether it's viral, or whether it's fungal, or it's nematodal. So you'll go for what? You'll go for CSF examination, and in CSF examination, what will you see is that elevated opening pressure will be there. You will pop into there and it will burst with fluid. So it's elevated opening pressure. Next on, you will have this white blood cell count of 150 to 2000 microliter per microliter. We talked about you're going to have leukocytosis. Next on, you will have eosinophilic pleocytosis of more than 20. We talked about eosinophils are going to be higher in any nematodal infection. Next on, we'll have protein concentration elevated. And finally, you will have glucose levels normal. Now, all of these findings in the CSF will lead us to our definite diagnosis of nematodal, or what we call as eosinophilic meningitis, which is caused by nematode, which is caused by strong elicit, this phenomena. So what you do see is that in this CSF examination, elevated opening pressure will be there, leukocytosis will be there, eosinophils will be higher, protein concentration will be higher, but what's going to be normal is glucose because they don't utilize glucose whatsoever. Now, how do we treat such patients? How do we treat angiostrongylodiasis? Right? So, how do we treat it? We give analgesics because we talked about we are going to have excruciating pains. Next on, we'll have these sedatives to temper a person off, to relax them. Maybe they're having these seizures, maybe they're having these paresthesias. You give them analgesics, you give them sedatives, they'll lower their pain, they'll give them some rest. What you do give afterwards is glucocorticoids because glucocorticoids have proven out to be very beneficial in such cases in which these nerve involvements are present, in which nerves are being entrapped and being affected. You give glucocorticoids to the patient and then you go for the lumbar puncture. Lumbar puncture has also proven out to be very effective in the treatment of angiostrongylodiasis. Now, last but not the least, gnathostomiasis. Gnathostomiasis is a phenomenon or is a pathological procedure which occurs because of Gnathosoma spingerum. Right? So what's happened? What's going to happen? This is the life cycle of it. We talked about some part of the life cycle in the very first slide, right? At least this part of the life cycle. But Gnathosoma spingerum will be revolving around this life cycle. Let's talk about it. First of all, L3 larva, or we talked about what larva we consider mature is L3, at level of L3. And L3 larvae develop into adult worms in definite host from tumor in gastric wall. What are the definite hosts? Pigs, dogs, cats. Now these are the definite hosts. So an L3 larva is going to develop in the gastric wall in the tumor by an adult worm. What's going to happen afterwards? Unembryonated eggs passes away in the feces, which will lead to what? Eggs are going to get embryonated in the water. They're going to lead to this L3 stage. Eggs hatch and release L1 larva, which will lead to what? Which will lead to first intermediate host ingestion of L1 larva by what? Molts twice to early L3 stage. So this goes to these fishes, these snails, these frogs, they ingest them. Afterwards, this grows to advanced L3 level of larva, which we consider mature larva, in tissue of the second intermediate host. Now, this was the first host, or the primary host, or the definite host. This got into this, afterwards got into these fishes and frogs, which are second intermediate host. They grew into these L3 larvas. Now these L3 larvas are going to be picked up by what? Infected second intermediate host ingested by this definite host. Now these frogs, these fishes, all of these are going to get ingested by what? These definite hosts we have. Cats, dogs, pigs. But in some cases, snake, ducks, all of these are involved by whatever means this paratenic host or these hosts that come along very oftenly are going to ingest them. They're going to harbor these L3 larvas, and then these are also going to be picked up by what? These dogs, cats, these pigs, which are definite hosts. So this completes its life cycle by going through what? Through two intermediate hosts, and then it goes on to these paratenic hosts in some cases, and then goes on to its definite host. So what we see here is that in no case or in no scenario it wants to affect a human. It wants to affect a human tissue. But accidentally, if we ingest them, an L3 immature adult undergoes aberrant migration into the human host. It will go in, it will lead to what? It will lead to tissue, and in the tissue it will cause these pathologies that we're going to talk about. What clinical features it will harbor? What clinical features will be there? First of all, you will have pain. Pain why? Because of this organism, because of these infection that's going to cause, because of this pathological consequences it's going to cause. It has rather very major cutaneous manifestations as well as you can see in this. You will have these pains, you will try to scratch it, you will have these raised lesions, you will have eosinophilic or periorbital area will be involved. So you'll have eosinophilia and periorbital area will be involved, and you can see eosinophilic or periorbital area being involved in this scenario. You will have cough because of the lung involvement. You will have hematuria. Now hematuria, because if it's going to affect your lungs, it's going to cause cough, but it's affecting your kidneys, it's going to cause what? It's going to cause hematuria. It's going to cause fever because of the ongoing infection in the blood, and it's going to cause swellings because of the scratchings you have been doing for a very long time, and it's going to cause what? Eosinophilic meningitis with myeloencephalitis. Now this is rather drastic pathology than even strong ileasis, right? This will lead to eosinophilic meningitis, but with myeloencephalitis. Now afterwards, what will happen? You will go for the diagnosis and treatment. You have known the drastic consequences or the clinical features of gnathomiasis. What's going to be the definite diagnostic tool we have? We are going to do what? We are going to go for the cutaneous migratory swellings, examine them. Then we go for periorbital eosinophilia. Then we go for ocular or cerebrospinal involvement. Then we go for eosinophilic pleocytosis. Then we go for surgical removal of the parasites. Now all of these manifestations or all of these clinical features that are coming along, and we are examining them with our diagnostic tools, all of these will lead us to our diagnosis. We'll start with history, we'll go for the examination. In the examination, you'll do what? You'll go for the cutaneous migratory swellings, you'll examine them, and then what? Then you'll go for the diagnostic tools in which peripheral eosinophilia will be checked, ocular and cerebral manifestations and involvement will be checked, eosinophilic pleocytosis will be checked, and then surgical removal of parasites will be carried out afterwards. That's the treatment, only treatment modality we have for it. But what's the treatment modality in the term of medicine? Okay, we remove these parasites surgically, but if not possible, what's the medical treatment we have in our stores for gnathomiasis? You give the patient albendazole, ivermectin, and glucocorticoids. Now, albendazole has been a very common drug in all the nematodal infections we have talked about up till now. Now it's not being used very oftenly because we have it given to so many patients at so many intervals, at so many times, that its sensitivity has decreased over the time. That's why we have these second line drugs. That's why we have these glucocorticoids in line to treat the patient if it's not responding to albendazole. So that's all for today. That's all for the topic regarding tissue nematode infections, all those nematodal infections which were not preying on us, which were not trying to get into our body, but somehow in their life cycle, they were eaten up by us. They were in contact with us and we ingested them. They move into our tissues. They cause these cutaneous manifestations we talked about. They cause these ocular manifestations we talked about. They cause these visceral manifestations we talked about. We talked about different clinical features it will present to us with. We talked about what kind of meningitis will be caused. In what cases it will be just eosinophilic meningitis. In what cases it will be eosinophilic meningitis with myeloencephalitis. How do we diagnose these parasites? What are the diagnostic tools best suited for diagnosing such parasites? And what do we give in the treatment of it? Either it's medical or surgical. So that's all for today. Thank you for watching sqadia.com.